Good evening, everybody, and welcome to the ICA webinars, which are being held every Wednesday for more than 1.5 years. They become very popular, and we are very glad that we get very good feedbacks from the audience. Just a little word about the Indian College of Anesthesiologists. This is a body which was registered in 2008 by a group of senior faculty academicians with the aim of having uniform education standards throughout the country. They have been holding many subspecialties and regional offices all over the country. We have affiliations with SAMBA as well as the American Society of Anesthesiologists. So for all of those who want to become members of the Indian College, we have a website, go on to that, and please get registered. Coming to today's webinar, it's a very interesting webinar, the title being Beyond Consciousness. We as anesthesiologists are so used to unconsciousness, but this is beyond consciousness. And for this, of course, we have two very senior and eminent anesthesiologists, and so also the moderator, who is a very senior and very eminent anesthesiologist of the country. The moderator is Dr. Babitha Ghai. We all know her. She is the professor at the PGI Chandigargh. Of course, she is a senior consultant anesthesiologist, but we always associate Babitha with all the pain activities. She is a very active participant in not only the national, but the International Society Association of Society of Pain. As you can see, she has held several international positions at the IASP as well as national. And she has had several grants. And of course, it goes without saying that she has more than 100 international and several national publications. She's extremely, I should say that she is very confident, and she has received several awards, including ISA Presidential Award for Academic Excellence last year. So Babitha, she will be moderating the session, and could you please start the session, please?
Thank you, ma'am. Thank you for your kind words. So moving on to the session, it's my proud and pleasant privilege to introduce one of my very fond colleague and senior from AIIMS, where we have worked together. It is my pleasure to introduce Dr. Balachandar Subramanyam, who is a professor of anesthesiologist at Harvard Medical College and is also a director of Sadhguru Center for a Conscious Planet. He has, in fact, established this center at Boston, associated with Beth Israel Medical Center, and he has a special interest and passion about going beyond the consciousness or beyond the unconsciousness. So this is the topic of his talk, that is a confusion of unconsciousness or consciousness in anesthesia, his experience as well as the mechanisms. Over to you, Dr. Bala.
Thank you, Dr. Babitha Ghai and Dr. Jayashree Sood and everyone else in this forum. And also thank you to the Indian College of Anesthesiologists, a wonderful initiative to unify and streamline education across the country. I'm always fond of where I come from, and also I really want to contribute and learn continuously as we go on in this journey. So let's just switch. And I'm really, I was thinking I was going to talk more about the anesthesia point of view, and wherever possible, I'll try to share my own personal experiences about going beyond the consciousness piece. So let's just focus this talk mostly on the mechanisms of anesthesia and consciousness. Without further ado, I have several disclosures, none relevant to this particular presentation. And this is where I come from, where I work. It's Beth Israel Medical Center, one of the Harvard Medical School hospitals, and this is Boston. Let's just cut the chase and go to this question. I've always wondered how actually anesthesia induces unconsciousness. And we have been doing this for almost 200 years, and we really don't know whether we understand the whole thing. And about 6 or 7 years ago, I had the privilege and opportunity to interact with one of the foremost authorities of yoga in India, that is Sadhguru. And I asked him, can you explain how anesthesia produces unconsciousness? And he just laughed at me and he said, just casually, nothing can touch consciousness, and all you guys are probably doing is just taking away the memory. This kind of stunned me, because that is not what I learned over the 20 years that I've been associated with anesthesia. And he didn't explain it any further, and I had to really find out more and more about this. And still, till date, I'm not sure that I really understood it. Of course, it set the path for going into the world of meditation and trying to understand what our traditional wisdom knew for such a long time, for many millennia. But I myself had discarded all these views, being arrogant as an allopathic doctor and not really paying attention to these traditional wisdom for a long time. So once I started doing this, I learned there's a lot more than what I really know. And all we know is just scratching the surface, and just brought humility and nothing more. And as usual, any inquiry just leads to more and more questions, and more, makes you more and more humble. So here, Christoph Koch, who's a leading scientist from the Allen Institute of Brain Sciences in Seattle, was wondering this with the same question: how does a 3-pound organ with a consistency of tofu exudes the feeling of life? He's just basically asking the same question in a different way. What is consciousness? As our yogis and Sadhguru also talks about, what is there in life is nothing but experiencing the moment to moment of the life, and also how much impact you create on others. That's it. And so that feeling of life that you get is, how does this organ produce? Or is this the only organ that produces it? Or there is more to the mind than just the brain. People are interested. We have also hosted an educational webinar on mind and brain with Stephen Loris, an eminent neurologist from Belgium, who is also in this journey of finding out, is brain sufficient to produce this consciousness? So let's just go to this Nature paper that was published. And they were talking about, we all know these individual lobes, and no one needs to know. If the lobe is very local, without much of connections to other parts of the lobe, they don't probably contribute to the consciousness a lot. For example, if you take cerebellum, which is important for maintenance of your stability, it is not really necessary that you have to have cerebellum for producing this feeling of consciousness. Similarly, if you have a frontal lobe lesion, still people can be conscious. So Christoph Koch and a bunch of other scientists figured out that the most prominent part of the brain that lights up during the consciousness experience is the parietal lobe. So maybe, is there a way that we can actually measure the consciousness experience and monitor that? And if we do that, maybe providing anesthesia becomes very easy. So Emery Brown, who's a prominent neuroscientist from the Harvard MIT area, he talks about how we need to come up with monitors that can actually measure the amount of consciousness. We know that there is something like EEG monitor, but is that enough? Do we not need to go beyond that? Unless we ask these questions, there is no way we can evolve. But it is fascinating to see that the portion of the brain that is actually lighting up in every measurement or in every experiment during this higher order consciousness is the parietal lobe. If you look at the traditional wisdom, they also talk about bindu, which is a small area in the posterior portions of the brain, where people cover it up with turbans, or the Jewish people put a little clothing around that area. So that seems to be an important area for them as well spiritually. So I don't know the relationships here, but it seems like the parietal lobe is the one that is lighting up in all processes of consciousness. So there are several things that we can use to probe this consciousness level. We can use anesthesia, that is where we come from, or the sleep researchers try to use sleep and then try to correlate that with the higher levels of consciousness, and disorders of consciousness, which is where neurologists like Stephen Loris comes from, where they look at minimally conscious states like locked-in syndrome, where people are hearing everything they're saying, but they have no response. They're unresponsive. So again, giving this idea that unresponsiveness doesn't mean unconsciousness. So often we quantify anesthesia as 50%, we all know about the MAC, and people don't move to a certain level of the anesthetic doses, etc. So there are various ways that we can probe this consciousness levels. As an anesthesiologist, what is interesting to us is this question. There is regularly 1 to 2 per 1,000 patients who are anesthetized do have this recall. It could be implicit awareness or it could be explicit awareness, right? It could be implicit memory or explicit memory, where you need to go and ask the questions to figure out the awareness, or they might come up with spontaneously recalling some things that are happening under anesthesia. So that actually supports the idea, the notion that Sadhguru talks about, that loss of memory is the only thing that happens during anesthesia, is because you do have people coming back with this awareness, a recall. Traditionally, we define how does anesthesia cause, people talked about unitary hypothesis in the Mayer-Overton rule. The higher the lipophilic the agent it is, then it can actually disrupt the membranes and leads to, because all our membranes are lipophilic, so that probably leads to a state of fluid, and so they do not actually produce the consciousness experience. But there are problems to this particular theory, and they are saying that they all should act at one site, which means that the cell membrane is probably the site they are talking in terms of lipophilicity. So is that enough to answer, right? Cause anesthesia, and we know that an alteration in temperature can disrupt the membrane, does not cause anesthesia. So it seems like just temperature alone cannot do that. We all know that immobility, amnesia, and absence of awareness, they need particularly different doses. It's not like one dose can produce all these three responses at the same time. And so are we sure that just the lipophilic action is enough to do that? We're not sure about that. Inhaled anesthetics on spinal cord can just produce immobility. So talking about loss of mobility as an equivalent of unconsciousness is not enough explanation. And we can have low doses of anesthetics causing amnesia, that is memory loss. For example, we have midazolam, just produces amnesia, and we have all heard of the isolated forearm technique, where the patient was responding to every question under anesthesia. They would move, you can actually have a conversation, but right after the anesthetic, they just completely deny remembering anything that happened during the anesthetic process. And our favorite theory that is currently working is you go ask every resident or MD graduate, they will talk about the ion channels as the main way these anesthetic agents act. Okay, so what? What happens after that is the main question. We all know the GABA, which is an inhibitory agent, is activated by these intravenous anesthetics like barbiturates, propofol, and etomidate, similarly by the inhalation anesthetics. Whereas ketamine will potentiate the NMDA receptor, which is basically something that excites it blocks the NMDA receptor, and it's an antagonist. And so NMDA receptor is an excitation for the ions. So, and they have different levels of activity in different ion channels. We all know that. But the question is, what happens after that? That is probably the question. So one of the simplest explanation that I've heard from Emory is, if you have a very long bridge, we've all gone to the northern parts or the Himalayas, where you can see the two big mountains are connected by very long bridge without any support underneath. So if there's a big wind, the bridge will actually be undulating like that. So here, one of the common examples in the US is the Seattle-Tacoma Washington Bridge, which is a very long bridge. With a wind, people cannot pass through. The bridge is still there. So similarly, during anesthesia, it seems like your brain goes into this slow motion where there is no information passing through this, and that is probably the reason why you produce anesthetic states, or states that are unconsciousness and unresponsive states. That seems to make a lot of sense to us. And if you take the ion channels, anesthesia itself has different things, right? You can have explicit memory blocked, perceptive awareness is blocked, movement and response to pain is blocked, and then you also have autonomic responses that needs very high levels of anesthetics. So just going with the ion channels alone doesn't explain everything that we can talk about, various aspects of anesthesia. So no single receptor site can explain that. And we know that different doses can produce different levels of
anesthetic components, and you can still have implicit memory in the absence of consciousness. So we have no clue how these things act, although we are scratching the surface about, what do these drugs do. So we need to really go beyond that, understand how do these things cause. So is it unconscious or is it unresponsive? We know that anesthetics in dose adequate for sedation in the low states, we all have had one sip of wine or alcohol or whatever. The initial state that you have is a drunkenness, distorted time perception, depersonalization, and you might just slowly go into sleepiness and amnesic states. So it seems like the neurons will be oscillating between a depolarized up state and a hyperpolarized down state. So that is known as the amplitude modulation. So when you monitor EEG, that is what we are looking to call that as an ideal anesthetic state. So if someone has SedLine monitors, they are looking at the raw waveforms coming out of these four EEG channels from your frontal portions of the brain. And you can look at those and you can see the amplitude modulations, that is high voltage but low frequency modulations, and then going down to complete bus suppression states and going further. Higher doses of anesthetics, you can basically have EEG bus suppression, and those are the states where people don't move in response to command. And that is your old definition of anesthesia and unresponsiveness. We all commonly talk about dream states. If you talk about any spiritual master, they will define these states of consciousness using dream states as one big example. You can have vivid conscious experiences, but you're completely unresponsive. So there is a brainstem inhibition that leads to muscle paralysis, which is why you are unresponsive in the dream states, but you have complete conscious experiences. And we all know that we can recall sometimes the dreams that we have. Paralyzing agents, they just cause unresponsiveness, but patients can be responsive. How many times we have seen that the recall states are increased in paralyzed patients because we're not giving adequate amounts of anesthetic in those people. Individual anesthetics, when you look at them, propofol and thiopentol, right? If you take a thiopentol, it seems like most of its action is in the posterior region. Remember the first slide that I talked about, where the posterior parietal regions and the superior occipital regions are the most ones that get excited during consciousness states. That area is blocked by thiopentol, whereas propofol and thiopentol whereas propofol blocks both areas, that is the anterior and the posterior zones. So it seems like the agents can also have different actions. When you look at inhalation anesthetics, they seem to be a little bit more dirty. For example, they can cause these effects in all portions of the brain. So when you look at EEG, when you see the frequencies, you can have very strong frequencies at 0 to 4 hertz, 4 to 8 hertz, and 8 to 12 hertz with the inhalation anesthetics. Whereas with propofol, you see mostly a 0 to 4 and 8 to 12. It seems like inhalation anesthetics have a very larger areas of action. So that is also something important to know where all these drugs are acting. Dexmedetomidine by itself may not produce completely anesthetic states, but it can reach up to there, like 70 to 80%. And they seem to be the central alpha-2 agonistic mechanisms. And you can see how and where they act, the ventrolateral preoptic nucleus, which is very often talking about the sleep states, etc. So dexmedetomidine is probably one of the anesthetic drugs that is very close to producing natural sleep. Anesthesia and sleep are not the same. They can produce NREM types of sleeps, but still anesthetic states are very different from the sleep states. Opioids by itself cannot produce anesthesia, but can produce certain amount. It can contribute to some anesthetic states, maybe about 60% or so. And that is when you take the peripheral afferent neurons and go up all the way into the pain pathways. So different agents act at different portions of the brain. What are the EEG characteristics? And this is interesting for us as anesthesiologists. I hope more and more people start using the EEG in their operating rooms. Otherwise, we're still flying blind. What is the point in flying blind when you have a monitor, which is very simple, not that expensive, and look at the actual waveforms there. So you can argue how much ever you want. It doesn't take away the awareness and recall, etc. But it can actually reduce the amount of anesthetic that you really need to give, especially with more older population, more sicker patients coming to us. Why not give just the amount of anesthetic they need instead of just giving calculated anesthetics and putting them into deeper anesthetic states? There is more evidence that comes out. I think there was a paper that was published recently in BJA that talks about deeper versus lighter anesthesia and increased amount of post-op cognitive decline. It's a balanced trial. It was a part of the balanced trial. The balanced trial itself talks about increased mortality I don't think it showed any differences in the mortality part, but it's the cognitive differences which we see. Cellular mechanisms of the conscious processing. So it seems like what happens after the ion channels are blocked, just want to go a little bit more deeper. These theories, they talk about the cellular theory. So you have dendrons and then you have axons. So this is just the dendron itself. You divide the dendron into three portions: the apical portion, the mid portion, and the basal portion. It seems like the apical portion, when it gets stimulated, it is responsible for segregation and also streamlining the process. And then it gets coupled in the mid portion, and then it goes to the basal portion of the dendron. And then that gets transferred into the axons. So it can be context specific, or it can be feature specific. So you can have different levels of consciousness based on these. And these portions are much more important. And this is probably the mid portion is the one that probably gets affected by the anesthetics. And that leads to the information processing or lack thereof as responsible for the anesthetic states. When you look at these two common theories, the global neuronal workspace theory and the integrated information theory, the IIT theory talks mostly about the posterior portions of the brain, and the global neuronal workspace theory is from frontal to parietal to occipital and the basal portions. It's global all over. When you take these and look at the individual dendrons alone, there is a top-down feedback that goes from top down, and there's also stimulus that goes from bottom up. That is all the sensory organs that gives it. So here is an example that talks about the first thing when you enter spirituality that they say is turn off all your sensory organs and pay attention to the inner self. So here you can look up this bottom up feeding to the consciousness process that is completely taken off, and still you experience very higher levels of conscious states during the spiritual processes or meditation. So it seems like anesthetic states actually take this portion out. That is the portion that combines the top and the bottom together and takes it out. And you can see that that happens to all the dendrons throughout this brain. And that is more and more evolving now as a cellular mechanism, how the anesthetics produce unconscious states. So explained differently, you can see that the consciousness experiences, this is responsible for the conscious experience. So without any sensory input, you can still have consciousness in the spiritual world. And in this experiment actually talks about that, how this is possible. Whereas this portion, when you take away with anesthetic, then you end up in the unconsciousness stage that is produced by the anesthesia. So what we're trying to talk about is cortex and thalamus are more important. Thalamus is probably just a readout of what is happening in the cortex, but cortex itself is probably enough to have the consciousness experiences without even having any input from the thalamus. So this is basically trying to tell you that, yes, thalamus is very important. When you take some GABA agonist and inject into the thalamic state, thalamus, you can probably lose your consciousness. And but that action is taken out. If let's say that in animal experiments, you remove the cortex and do the same thing with thalamus, then you don't have that same response. So it seems like thalamus is just a reflection of what is going on in the cortex. It's important, but by itself is not enough to explain the consciousness process that we have. And why it is important, you can also see that during the anesthetic stage, the metabolism in thalamus actually goes down. That is probably reflected because there is decreased metabolism in the cortical regions also. And I talked about the GABA injections. And you can wake up patients from the unconscious states by injecting something like nicotine into the thalamus also. So it seems like it's an important organ, but by itself, it's not enough to explain the entire process. So now we are doing more and more deep brain stimulators. Now neurologists are actually doing much more interventions to patients with epilepsy or people with neurodegenerative disorders, and seems like that can be another probe that can be used to know a little bit more about the conscious states. So the cortical effects of anesthetics evoked responses in primary sensory cortices. That is not just enough to shut down the sensory cortex. You can have all kinds of input into your sensory cortex, but you can just how to down-regulate it by meditation, etc. When these areas start to turn off, subjects report dream-like states. We are talking about the mesial parietal cortex here, and the posterior cingulate cortex and precuneus. Again, go back to the first slide where I talked about the posterior regions getting stimulated during the higher order conscious states. And if they start to turn off, people report something like this, out-of-body experiences, etc. So it seems like even more needs to be done to understand the consciousness experiences. But you can see that that seems to be the major portion for as of now to know that. So it seems like comprising the lateral temporo-parieto-occipital junction and perhaps a mesial cortical core are most likely the final common target for anesthetic-induced unconsciousness states. So now the next theory that comes out is a cortical integration. So let's take that this is a dice, right, with multiple faces to it. And in an anesthetic state, what happens is this dice falls into pieces, like these individual pieces. If they're not together, there is no relay of information. Things are not integrated. And we know with meditation, the right and left side gets integrated. And we also know with fMRI data that there is a lot of integration that takes place for the entire brain. So that may be the reason why we perceive higher order consciousness states. Whereas with anesthesia, that integration is lost. So if you look at these two, the feedback and the feed forward, this is frontal, this is parietal, and this is occipital portions of the brain. Green portion is where the information is going from the occipit to the parietal to the frontal regions. The feedback is the feed forward information and the feedback information, whereas the red one, the red markings are the ones that is coming back from the frontal to the occipital regions and parietal regions. They are the ones they're affected by the anesthetic states, especially with the early on anesthetic states. You can see that with anesthesia, that red marking goes down. And so the information coming from frontal to the parietal to the occipital regions is reduced. And they've also done other experiments where they've seen that if there is a stimulus that is given into these posterior portions of the brain, in the awake states, it seems like it can go in a very orderly fashion to the other portions of the brain. Whereas in the asleep states, that is lost. It's more like a ripple that you see in a pond. So again, talking about the integration information and what we know about meditation, etc., seems like it makes a lot of sense that the cortical integration is lost, and that's why you get into these anesthetic states. And it seems like only you need to take off just a few long-range connections to produce a set of disconnected components. It's not like you have to act in every part, like frontal to parietal connection or parietal to occipital connection, etc. I also want to quote here, the first thing when you go for meditation, they ask you to close your eyes. I used to wonder why they do that. It seems like 60% of the sensory input is all coming from the eye, from the optical region. So it may be the reason why people who are blind actually have very higher perceptive states, and they're just not wasting their majority of the brain integrating information that is useless coming from the occipital cortex. There's the next thing is the information capacity. It's not just integration, but it's also information capacity. So this same dice example, this can just collapse into one triangle. It becomes from a 3-dimension to a 2-dimension. When you have that, you lack the ability to integrate information. So for example, we all think about epileptic states, but they still act unconscious. Why is that? You have a very high, excited state, but you don't have a conscious experience. It's probably because they're neither able to integrate nor able to have this processing of information. So that explains the ketamine states as well as to why you produce anesthesia with ketamine. So simply put all these things together, it's called the cognitive binding problem, right? Binding by convergence, what happens when new objects are presented to you? And so probably everything is learned, and then you converge within your brain, and you now understand what that is. Binding by assembly, that is when orange and tangerines are presented at the same time. You put the information together by one after the other. That is just a linear issue. Then binding by synchrony, for example, the orchestra example, dream states or thalamic dissociations. If you don't have a synchronized information, then you're not able to process that really well. So the latest framework that is suggested is cognitive unbinding instead of binding, which is what the brain does to have this conscious experience. With anesthesia, you basically end up with this unbinding states affecting each one of these portions, this convergence, assembly, and synchrony, all of that together. And that is probably the reason how you end up in this unconscious states, and no information is passing from one to the other. And consciousness is not just all or none property. It's not like a 0 or 1 binary. It's a state of, it's a spectrum. So that again comes from, I can correlate to the meditation world. As you keep meditating, as you become, experienced in meditation and really internalize yourself, your consciousness experience is also increasing. So that seems like it makes a lot of sense to me. From with anesthesia, you probably keep going down and hit a point, and suddenly you just lose completely everything. So that is an example of non-linearity. It's not like an all or none property, but it's a non-linearity. So what happens during stillness? Do I, like that is exactly the higher order meditative states. What is happening then? Do we actually know that? That needs to be studied. Do I know my brain only through my thoughts? Or is there any other way that I know my brain? Is brain enough to cause everything about the consciousness experience, or the entire body is responsible for it? And if you completely go silent, what do you really feel? So all these things can be experienced with our traditional wisdom. Don't lose that opportunity. And being anesthesiologists, you're seeing both spectrums. It's such a wonderful opportunity that we have during a lifetime to experience both states. The yogic descriptions of conscious states, they talk about Jagriti, which is the wakefulness states. Probably we should, the way we understand consciousness is all about wakefulness. We don't really think we understand the consciousness states. Sapna is a vivid dreams, and Sushupti is a dreamless state, but you're still aware. Surya is intelligence without memory. So you have nothing there. All that is left in these portions is creativity. And it is such a wonderful state to be in, the Surya states. And I don't know how many people even hit those states. So, there are various definitions that one needs to go through. I don't want to go through all of this. And with that, I will end this conversation, and then we can take questions whenever the moderators allow. Thank you so much.
Thank you, Dr. Bala. Thank you for making such an tangled and complicated issue so simple. However, going through your talk, I feel that despite the fact I might understand that I have a learned anesthesiologist about the concept of consciousness and unconsciousness. After your talk, I feel that how much unlearned I am about it, that so much to learn, so much to explore, so much to go deeper into. And you have definitely provided the food of thought for thinking many theories and beautifully collaborating so-called consciousness, loss of memory, inner self, and beautifully given the examples. Thank you very much for an elaborative talk. Akriti, I think we would take question and answers, and we would keep it till 7:45. So we do have 10 minutes. I do believe Dr. Bala has a clinic to go. So if he stays with us, most welcome. We would be more than happy. But in case he might have short of time, so we can take questions in those 10 minutes. So can you put that questions in the chat box?
Ma'am, I'm checking if there are any questions.
Meanwhile, you can also leave it open. If there is no question in the chat box, they can always unmute and ask the question.
Ma'am, there are no questions in the chat box, and there is no provision for them to unmute and ask question directly. This is a separate link for the faculties only.
Okay. Okay. So
Yes.
you can just, ask them once more while I'm going to ask few questions. While I'm asking question, they can always place few questions in the chat box. So Dr.
Yes, so
Bala,
doctors, just 1 minute, ma'am. I would request the doctors who are attending the session to please post their questions in the comment box. I will be providing the questions to Babitha, ma'am. Yeah, over to you, ma'am.
thank you. Thank you, Akriti. So Dr. Bala, you beautifully said that BJ article recently published has mentioned about that deeper state of anesthesia, more than what is required, can lead to a cognition effect in the postoperative period. My question is, yes, this might be a research topic which is studied very well, but how do we judge that what level is required for an X patient, for a Y patient, because it is very individualized. What is not more, what is not less for a particular patient?
Yeah, great question. When you look at it, I talked about older patients and I also talked about sicker patients, right? So there is also another concept that you very well know, that is anesthesia sensitivities, right? Different people have different sensitivities to the agents that we introduce. So right now, what we are doing is using the hemodynamics as our endpoint to anesthetize patients, which is really gross. That is not the way to go. And we might even actually give drugs to support the hemodynamics in order to maintain it there. And of course, we cater to the surgeon's requirement that patients should not move, which we achieve partly with the paralytic agents and partly with the anesthetic itself. It seems like for everything, we only thing that we know is to turn on and turn off the vaporizers. So what do we have to actually monitor the brain? At this point, it seems like EEG is the only thing that we can do practically in the operating rooms. The BIS monitors initially that were introduced, it's a very reduced way of looking at things. It looks at multiple channels and then just gives you a number. It has its own advantages and disadvantages, more disadvantages than advantages, because of you can have states other than anesthesia inducing different numbers in there. So if you can actually monitor the SedLine monitor, which is the best right now available, the 4 channels that comes out of the frontal cortex during the anesthetized states, it should probably reflect the entire brain. You actually look for amplitude modulation as your endpoint. You do not try to avoid burst suppression. If you're avoiding something, eventually you always end up touching it. You don't want to even touch that. You want to live at the state of amplitude modulation, which is low frequency, high amplitude waves followed by low amplitude, low frequency waves. So you just keep looking at that as your endpoint. So we have shown in a Pathfinder experiment that was recently published, where we were able to actually reduce the amount of burst suppression even lower than the Engages trial, to a level of 0 to 4 minutes using that technique. We are working with Emory Brown to do that. So right now, that is the only thing we have. But people like Christoph Koch, etc., they're trying to see whether they can use this parietal stimulation as their endpoint for consciousness. So currently, this is what we have, and that's what we're monitoring.
Thank you, Dr. Bala. Thank you for your elaborate answer. That is where I would like the message to be passed to the residents, especially a resident from India. Like what the concept of BIS is so much inculcated in the MD teaching currently, that we need to be knowing the advantages as well as more so the disadvantages of BIS. So currently what we have been using as the anesthetic depth monitoring is the BIS, and that is the only thing. However, also, as you said, that the EEG should be the part of monitoring, which is not universally followed, which is also not in the guidelines or the recommendations currently mandatory. And that is also lacking, the teaching regarding the EEG is also lacking in the curriculum of MD anesthesiology. So I think this gives us an open food of thought to maybe later on or during this process of learning process, we incorporate depth monitoring the equipments or the monitors in anesthesia, and BIS itself is not a very good reliable monitor. Its sensitivity and specificity is not very good. So thank you very much. Do we have another question, Akriti, from the participants? Then I can go to my second question if required.
Can I ask a question?
Yeah, sure.
Very nice talk, Bala. And I was just wondering if you have reviewed any literature, or is there any data to show how the meditators, what is their outcome when they're on your table versus non-meditators in terms of, as you explained, information capacity, integration, or whatever outcome?
I have some theories, but there is no data. I have some theories based on my own experience, because as you know, at this age, we undergo colonoscopy and things like that. So we are like mosquitoes. We really don't need that much amount of anesthetic to put us to sleep. Like with 2 of Versed, I can sleep for like 2 hours. I actually ended up doing, they ended up doing that for the entire colonoscopy process and whatever else they needed to do. So I was wondering why, with fair amount of meditation, 6 or 7 years of doing that, was that the reason why we end up having to need only lower doses of drugs? So my thought process is, it probably, hopefully, I don't know whether it's really true. If you're really integrated well, it's like you touch one end, the other end goes and falls, because everything is connected. So it's very easy to anesthetize meditators, probably. We want to study that just for that reason. You also know that, Akshay, that people who meditate or do yoga, etc., they are also highly perceptive. For example, they probably have a lot of pain perception during the process. In a smaller study that we are doing in patients undergoing hip and knee joint surgery, we are giving them guided meditation, Isha Kriya, 3 weeks prior to the proposed surgery. And it seems like they need more opioids during the surgery, but they come off it very quickly post-operatively. Whereas those who do not do this meditation, this is a randomized trial, they actually tend to take opioids for a longer time in the post-operative period. So that I was wondering why that was. It's probably because you become very perceptive of pain, and so you tend to need more during the process of pain itself. But there is also another angle to it. Pain and suffering are very different, where you have the pain, but you can tolerate it no matter. You won't complain, you won't ask for it. So suffering portion is reduced. So it seems like there are a lot of components to these. So anesthesia itself, when you look at the brain, maybe because of integration and connection, you touch one side, it just falls apart. You don't need much to anesthetize. But management of pain, probably you need to give more at the time of acute pain. If they complain of it, maybe because there is higher perception, but they seem to come off it very quickly. So very long-winded answer based on our experience.
Thank you. And actually imagine that they might be more resilient and more open and more accepting, and they may actually fall off easily and come off easily. So, but that's very interesting.
Dr. Bala, can I add on to this? The one thing which you said, that they seem to be requiring more of opioids, and the theory behind was, and the hypothesis behind is that they are probably perceptive of pain. But despite meditators perceptive of pains, they are usually tolerant of pain. So they may not complain. So in that case, isn't it contradicting our theory and the hypothesis that they should be requiring less opioids?
Yeah, so if you're under anesthesia, right? I talked about requiring more medications under anesthesia. You are giving medications based on the autonomic changes or the heart rate and blood pressure changes. You're not having a pain monitor. Patient is not saying anything to you. So it's very different. Whereas they come off it post-operatively, they may not complain. So they may need less. That's what I meant.
Thank you. So, Dr. Bala, welcome, sir. Any question from Dr. Bala and Dr. Jayashree?
No, that was a very excellent talk and very thought-provoking. And of course, we have a lot to read if you can go on and on. And thank you very much. I think if you want to go on to the next one. Thanks, Dr. Bala. Thank you so much.
Thank you, Dr. Bala. Thank you for such an excellent, actually speaking, the thought-provoking talk. So we'll move on to the second talk of today's session. It is again my proud privilege, and more than proud, it is more of a pleasant privilege to introduce Dr. Akshay, who is a dear friend of mine and who is a very passionate person regarding the non-clinical aspect of clinicians. So he has a huge passion about yoga, and he is a professor in Department of Neurosciences Research Lab, Department of Neurology at PGIMER Chandigargh. He is also the director of CCRYN, that is a Center for Research in Yoga and Naturopathy, Collaborative Center for Mind-Body Intervention by Yoga in PGIMER. He is the main lead of this collaborative center at PGIMER. He has major achievements to him, that is to his credit, lots of international, national achievements, and amongst that I would like to highlight that he has discovered the animal model of AMD, which is published in Nature Medicine, and he has been visiting the professor to various neurosciences labs or various departments across the globe, and which have shown special interest in yoga. And we have been collaborated with each other since long, and we realize that we both have shared the passion of use of yoga in both clinical practice as well as for the stress management of our resident. His area of interest are cell survival mechanisms and neurosciences. So Dr. Akshay would be speaking about stress and anxiety management in healthcare workers, more so in anesthesiologists, which has become actually, stress has become the integral part of all the healthcare workers, more specifically for the anesthesiologists, for the heck of the practice which we go, the clinical aspect which we face, be it intensive care, be it pain management, or be it trauma. So over to you, Dr. Akshay. He'll be speaking about stress management in healthcare workers.
Thank you, Dr. Babitha, Dr. Jayashree, and of course the ICA, and also thanks to colleague and friend Bala for a very enlightening talk. And it's a proud privilege to be in this forum, especially as Dr. Babitha rightly resonated my passion for yoga. And I thought it would be, I actually initially wanted to, just come live and speak without slides. But then Dr. Babitha prevailed on me, and she said that I should bring in some slides. So I thought that she was right, because then I put in a few slides, and they're no longer few actually. They're in quite more than about 2 dozen, but I'll quickly flip through them, and I am sure that this will make some sense. So the flow of my talk is going to be about what I and we have been doing in our research lab, and then go on to explain how our research evolved and entered the door of yoga and meditation. In fact, just yoga. Technically, meditation is a part of yoga, so yoga. And then I did some research about...
Sorry to interrupt you, Dr. Akshay. Are you flipping the slides?
No, I'm not. I'm going to...
Okay.
I'm going to start doing it now. This is me, and I'm going to be talking about the unique situation faced by anesthesiologists, my colleagues who've been the frontliners, especially highlighted during the 2 years of COVID around the globe. That's the banner of our research lab. That's our visual mission statement of how brain drain is impacting research in India and other developing world. So I thought I'd give you a brief overview of what we've been doing in our research lab, so that you will have some idea of how I entered into this field. We do, like any other researcher, work on animal models. First, we try to discover biomarkers through using collaboration with our neurologist friends and with focus on neurodegenerative disorders, trying to look for gene association with some of the Parkinson's disease, ALS, and other neurodegenerative disorders, and then use them to model the animals, and then rescue these animal models, their phenotypes, using synthetic analogs, herbs, and more recently, stem cells, as well as the extracts from the yoga practitioners of how they can alter or rescue the phenotype produced artificially in the animal model. So we are a quality conscious lab, and we've been working for almost 2 decades. And this is the evolution. There's been a lot of stress in my own professional career in terms of failing to discover a drug which could alleviate or reverse a neurodegenerative disorder. And I think it is shared globally by many of the neuroscientists like me, which is what led me to work on a field like yoga, because I thought I should focus all the paraphernalia used in molecular research, such as animal models, stem cells, biomarker discovery, to understand how it can help us discover the preventive action of yoga, and how it is, or how we can design yoga modules that can prevent the neurodegenerative disorders, or if not prevent, at least halt the conversion of neurodegenerative disorders such as MCI or TIAs into a full-blown disease. So we're using the same tools now after 20 years of research to explore the potential of yoga modules in various conditions. But our underlying molecular probe or search engine is basically the same, which is molecular biology tools such as PCR, stem cell culture, animal models, and stuff like that. This is inspired. This is nothing really very new, because we know that the wellness program is enshrined in Ayurveda, the traditional Chinese medicine. And this tells us about how the awareness about wellness emerged or evolved over the course of last 2,000-3,000 years back. It was in Ayurveda, and now more and more people are realizing the importance of a stress-free life, and which is devoid of lifestyle disorders. I was also inspired by the amount of budget that is dedicated to non-communicable diseases. It is so meager, and India is actually second last in the government expenditure on health. But I think we have not reallocated, at least 6-7 years back, until that time, not properly reallocated our budget and focused more and more into pharmaceutical research than non-pharmacological approach. As also inspired by this beautiful movie that was in the Indian cinemas a couple of years back. It tells us the plight of this couple who are trying to get their mother-in-law or mother of the gentleman and mother-in-law of the lady there. They are a couple of how they can meet the expenses for bypass surgery, which is largely preventable. And this is the message that really struck me, and I began to romanticize with yoga more and more. Not incidentally, Niti Aayog, the Indian Planning Commission, and the newly formed Ministry of Ayush has been focusing on the importance of bringing the non-pharmacological approach to the front. And they propose through different study groups that traditional practices such as yoga and even Ayurveda, how it can be integrated in evidence-based fashion in the practice of medicine. A lot of interministerial dialogue has been happening. Some funding agencies such as Ministry of Ayush and what is Satyam, which is a part of Department of Science and Technology, are funding such research projects. More and more net fellowships have been proposed. And like our centers, many more centers are coming up within the confines of a medical institute and colleges, so that there is more of evidence generation of the practice of yoga in variety of clinical situations. We are also hearing of Himachal Pradesh, one of the Indian states, to become a model state to do this. And several inter-university centers are coming up to make this happen. You might have heard of 150,000 wellness centers coming up, and about 10% of those will have an Ayush interface, which will work hand in hand with the clinical colleagues, the allopathic colleagues, such as you and other physicians, to roll out a preventive healthcare map, which revolves around yoga protocols and in an evidence-based fashion. So more recently, we heard of Ayush COVID yoga protocol, and this was proposed by the Ministry of Ayush. I have taken it from their website. A protocol for primary event prevention, a yoga protocol for post-COVID, and also for management of mid-COVID-19 cases. This revolves around the overall, the concept of yoga, which I will show you, very, very interesting Ashtanga yoga schematic that I'll show you. It includes the asanas, the standing, the lying down, the pranasanas, and the meditation aspect, all very nicely encompassed, ranging from 20 minutes to 30 minutes of protocol. And what actually is yoga? I could have put it as the first slide, but I brought it here because a lot of people now are already aware of what yoga is, but a lot of you may not be knowing that this is derived from a Sanskrit word yuj, which basically means union. Right? It's a union of mind and body. Body and mind was very slightly touched by Bala in the previous talk of when he talked of integration, when he talked of some agents causing paralysis and sparing the consciousness. So if we integrate the mind and body and align it well, it's yoga. And there are yoga methods that are enshrined in our yoga Patanjali Sutras given by Maharishi Patanjali. They are 8-limb path, as we may call it. And this is very interesting because this forms the basis of various yoga protocols that are being proposed and being validated scientifically. And they are also parts of them are being imported into different yoga schools such as Art of Living and Sadhguru, Isha Kriyas, and even other schools of yoga, Bihar School of Yoga, etc. They are all derived or are in different permutations and combinations or highlighting one aspect of it. So yama and yamas are basically the social moral dictates, the asana, pranayama, the physical postures and the breathing techniques. The pratyahar down there, the 5th step, is the process of bringing the senses inside for inner enrichment, and dharana, dhyana, and samadhi constitute what is the meditation. These, in brief, these are a combination of social moral dictates, the physical and breathing techniques, and the process of meditation. So meditation is very much a part of yoga, and we should not actually dissect it into yoga and meditation, although it has become a wrong practice. And now coming to your unique situation, you guys run the ICUs, and you have long standing and continuous sitting. And what could be a good way to ensure that you are in the right mind-body balance and are actually conscious as we want you to be, unlike your patients? And the suggestion is that a lot of stretching exercises, especially the inverted asanas, cycling, leg rotation, and what is known as Pavan Mukta series. And these are loosening exercises like shoulder rotation, ankle rotation, bending of the head rotation, and they can help. If this is done in the ORs, this can help in withstanding the stress of long standing and continuous sitting. Also, you guys have long irregular working hours, and you may be called to be present suddenly at the times when you're supposed to be sleeping, which may disturb your biorhythms. Pranayams like Nadi Shodhana, which is also called Alom Vilom, and Ujjayi, we may probably have some time to do it with me at the end. And this can really help in focusing and getting over the biorhythm, the disruption of the circadian rhythms. The dharana practice, which if you notice was in the last 3 parts of the Ashtanga Yoga, which is a meditative practice, can also be picked up. Pavana Mukta series 2 constitutes certain asanas. You can pick it up, and it's a long series, not in the scope of this talk, but that's why I mentioned Pavan Mukta. It is called the PM1 series. PM1 series constitutes a certain set of asana that can be very, very useful for the kind of work that you guys do. And Trata Kriya can help you improve and concentrate on the work that is at hand, which is requiring a lot of alertness and which is nerve-wracking sometimes. Stress is there in our lives, and more so in case of anesthesiologists. I suggest that Bhramari and Ujjayi Pranayama are very useful for this. Yoga Nidra is an adaptation, and is obviously adaptation to guided sleep in complete. It's very different from the regular sleep we get, which is full of awareness, and it can be managed by guided meditation. And we cannot do it today, but probably you can read it. And the other ways is the practice of awareness of breath, which is the heart of meditation. So these are physical and mental stresses that you go through, and these are the proposed solutions which can really help you to maintain a very good mind-body balance. This requires some personality changes, and which are very easily achieved by the yama niyamas, the first two social and moral dictates, which may require cultivating a sense of perfection and, what in Hindi we call Atmanirikshan and Atmasudhar. This is possible if we adopt a logical and a far-sighted and self-image, and this is possible by self-analysis and self-reformation. And how is this possible? By the same niyama and niyamas. And you can read it up. This basically includes the samatva bhav, the kshama bhav, the santosh, the sense of satisfaction or whatever you do. And in one way, if I can call it, less greedy or less materialistic life. And you're always confronted with unpredictability of circumstances, and that calls for an ability to adjust and adopt. So how do we ingrain these virtues of becoming really balanced and performing so well in such uncertain conditions? How do we adjust and adopt? So the yama niyamas parts of the Ashtanga Yoga provides a pathway to do this. And the asanas and pranayama are actually the tools to achieve that. And therefore, I thought this would be important to bring up this important aspect of a little bit of a overhauling of our personality to be able to accommodate and accept and adjust it. If you could read a little bit of Patanjali Sutra, this is a really good interface for us to start a journey on a yogic lifestyle. I thought it would be very captivating for you to know that this is something which is not new. The research in yoga is not in fashion just because of a certain reason or some VIPs are doing it or our Honorable Prime Minister is doing it, but it has been an old endeavor, as is clear from some of the experiments that were done by these stalwarts in yoga. Swami Kovalyanand, on his name, the Kaivalya Dham exists today close to Mumbai. Swami Rama and Yogi Satyamurti. I thought it would be fair to bring this up for your information. And some of these experiments were done about 100 years back in Kaivalya Dham. You can see the metabolic rate being assessed by the oxygen consumption here. That's Swami Kovalyanand overseeing along with Pandit Jawaharlal Nehru, the various experiments on yoga. And this is a very famous experiment, Ramananda Yogi, who is seen all geared up with EEG wires and everything before putting him into an airtight box. And he had actually shown, and this is published, that he could bring his electrical activity of the heart to a straight line when he was put in an airtight chamber. The research as it exists in PubMed, if you search yoga and meditation or just yoga, 60% of the research is meditation oriented. Very little research into asana and prana, which is an inherent part of integrated yoga. And I bring these research articles to you to convince you, because I propose some solutions for your unique situation in which you work in the ICUs, and also to bring forth a series of evidence of why Ayush proposed that COVID yoga protocol that I showed you right in the beginning. So it's a time when a lot of activity and funding is happening into developing yoga protocols for diabetes, yoga protocol for asthma, yoga protocol for obesity, and yoga protocol for stress and COVID management, etc., etc. So a lot of focus now beginning to shift from meditation to asanas. We put up this review, you can read it up, published in Neuroepidemiology, where we compared the effect of exercise and yoga, and how yoga has a superior effect on stress management through a certain pathway, by pathway which has cortisol as a major player, which can be suppressed very easily to reduce the impact on hyperglycemia and oxidative stress. And eventually, the diabetes-induced cognitive decline can be changed. I just put in this slide when Bala was speaking from another of the slide, because he was mentioning so much about the brain, the integration, and he was talking about information capacity. This is a study done on meditators brought from 2 years, 5 years, and 10 years of experience. You can see an increased glycation. And this is an imaging study just I pulled it in. Some of the research has already shown, and particularly coming from Elizabeth Blackburn, who got a Nobel Prize on telomere, shows that immune senescence is reversed if yoga can be. Yoga was when it was given to these 30 to 60 participants in Sand Yoga. The research was led by Lisa Apple, another colleague and also a guest faculty in our center, showing that these genes that were involved in stress response were suppressed. And these bunch of genes are actually altered in a manner that reverse the immune senescence. In brief, the immunity was increased by reduction of stress. Why are we not able to take this evidence into translate? Why aren't we able to translate this into our healthcare or healthcare workers? You were all seen in ICUs and were under a lot of stress when you were handling critical patients. Research shows that even if I show you loads of data of PubMed references of stress being reduced by yoga, different yoga protocols, and randomized controlled trials, these studies show that unless you practice it yourself, the literature itself will not convince you to adopt this into your own life, or let alone prescribe it to your patients. So this kind of study shows that unless the experience is internalized, and in addition, if you have the scientific knowledge to back up your new yoga lifestyle, you will not be able to adapt this. So this research is another reminder of how it can be useful to bring relief to patients if you yourself are, in Bala's words, more conscious and more meditative and more resilient and more open to adopt, to accommodate changes. This particular study was done on genetic counselors. Well, genetic counselors, deal with genetic disorders who have no relief at all, and these are irreversible. So there is a term called compassion fatigue, as you may have heard. This is pretty much applicable not only to genetic counselors but to you anesthesiologists as well. The compassion fatigue is far reduced, alleviated, if this was a study done on genetic counselor, but it is very much possible to translate this into anesthesiologists, because the compassion fatigue phenomena increases in many healthcare workers. This was very easily addressed by continuous periodic practice of yoga. The empathy increases, the compassion fatigue goes down, the burnout goes down. There is more work engagement and more empathy. We did the study into the COVID ward of PGI, funded by Ayush, basically using an adaptation of Isha Kriya. We, for technical reasons, called it a short breathing technique and a long breathing technique, 5 minutes for the COVID patients and 15 minutes for healthcare workers and the recovered ones. Small study, randomized controlled trials. We put in a lot of neuropsychological parameters, some biochemical parameters, some heart rate variabilities. And what did we find? This was a simple technique, and all we found was a reduction in the D-dimer levels. And we also found an increased distance covered in the 6-minute walk test. We are communicating this. Bala was part of this study. He was a consultant, and we together evolved this proposal and got it funded and carried this study out 4 months back. And this is, as I mentioned, this is all an evidence for you to convince you to take yoga into your lives, to be a better anesthesiologist, which is less stress-free. After all, we've had a life where we have attained everything in life. We have a food, we have a good care system, we get paid well, and still we are not happy. And still some of us are either having chronic disease or are vulnerable to it. So more and more protocols are coming up. This protocol development is a very scientific process, which includes the spiritual gurus who have a grip on Patanjali Sutras. Scientists are there, endocrinologists, surgeons, and other policymakers. They make what is called a Delphi protocol. And this is how the diabetic yoga protocol was made. Similarly, common yoga protocol, which we all practiced on the June 21st, was developed, and now other protocols are coming up. The one that I showed was the COVID-19 protocol of Ministry of Ayush. These are some of the eminent names. The most glaring, you can see Swami Ramdev, you can see Sadhguru, you can spot H.R. Nagendra ji, the Honorable Prime Minister's yoga guru. And these people sat together over different rounds and then came up with the sitting asana, a combination of sitting asanas, lying down asanas, prone asanas, some meditation practice, and came out with a 1-hour diabetic yoga protocol and a 45-minute common yoga protocol. I will show you some pictures to enthuse you, to inspire you to take up this as a study. in your own practice, and then maybe as you practice, if this can be a part of your research agenda, I think you will be as excited and more excited and maybe less stressed when you generate data where the practices of yoga and meditation can act as an augment the various agents you use to anesthetize the patient. That's why I asked Bala, how do the meditators perform on a table when you give them anesthesia? So this is a study how we put together the people and gave them diabetic yoga protocol for 3 months. This is pictures to show how we, took their measurements and blood, and 3 months after we took the same measurements again. And what did we find? We found that the conversion of pre-diabetics, which were screened from across the country, 62 districts of India, again a study led by SVASA, Dr. H.R. Nagendra, and the North India part was looked after by our research group. And this is just one paper. About 24 papers have come out. In brief, what we showed was that about 50,000 people that were found to be pre-diabetic when they were given this diabetic yoga protocol for 3 months. And when the various parameters were analyzed, we could show that there was the pre-diabetic conversion into diabetes was halted significantly. So these came out as different papers, some just focusing on dyslipidemia, others focusing on chronic stress, on hypertension and stuff like that. We even showed that the pre-diabetics had higher stress levels analyzed by PSS scoring as compared to the diabetes. And we almost propose that it is the stress which basically rides the conversion of pre-diabetes into diabetes. This may apply to pre-Alzheimer, which is MCI. It may apply to pre-stroke, which is TIA. It may apply to pre-cancer. It may apply to pre-wet AMD, which is AMD, dry AMD, and stuff like that. So a good tool for us to use it as a good subject or a population to study could be a pre-disease state. And in your anesthesiology investigations and your own practice, you can identify such states where you can pick up a pre-disease state or a pre-intervention state and give a yoga intervention or a yoga module intervention, study the outcome. We also showed that the common yoga protocol we use on June 21st can increase the angiogenin levels, which are one of the neurogenesis and neuroprotective agents. So therefore, this is pretty much an evidence why we all healthcare workers and scientists should adopt this in our own lifestyle, practice common yoga protocol, diabetic yoga protocol based on whatever we are doing. A study which we did all across the country on how the yoga practitioners performed versus the non-yoga, whose coping skills were better. So we showed in paper published in Frontier that the coping skills of the yoga practitioners far higher than the non-yoga practitioners. Similar such studies done at high altitude showing the PO2 levels can be controlled in a significantly superior fashion as compared to the non-meditators. More studies. And finally, I'll conclude trying to bring your attention and bring this point to discussion of having known so much about the benefits of yoga and meditation. Why are we not able to translate this into our own medical practice? Why are we not able to adopt this lifestyle in our own day-to-day living? So we did a study about 100,000 people, asking people what are the benefits and what are the barriers. Most of them said, yes, it makes you feel good, you feel healthy, you feel great, you feel relaxed. Now, what are the barriers? Most of them said, family life, no encouragement, nowhere to go. We have no access to yoga practitioners. So now we have an accreditation system by which you can, and we have an online tele-yoga guidelines, which were brought out by the Ministry of Ayush, by which we can, access the yoga practitioners for such a thing. And now the 150,000 wellness programs, which have 150,000 wellness centers which are coming up, have about 15,000 of them integrated yoga modules with it, the yoga practitioners available. So when we ask people, the same 100,000 plus people, do you know yoga can be helpful? Do you know yoga can help you prevent lifestyle disorders? Most of them said yes. And yet even 10% of the Indians practice yoga. So there is a big gap that we need to work on together. And this is where we can, together as healthcare workers, as scientists and investigators, bring relief to our patients, prevent the healthcare budget from escalating, and come up as more fitter and mind-body balanced healthcare workers as anesthesiologists, to bring more relief to our colleagues, more positivity and more cooperation within our own ecosystem where we work, as well as a better outcome, better patient healthcare outcome, and to be able to deal with emergencies and uncertain and unpleasant situations in the OR with the practice of yoga. So this is what I said was all theory and some ideas and concepts, some reflections on what Bala said. So I think this will have no meaning unless we practice a little bit. So how about going through a little bit of meditation? And as I started, when I showed you the slide of Ashtanga Yoga, I told you that the last 3 steps, Dharana, Dhyan, Samadhi, are basically meditation. But Asana and Pranayama basically make you makes the right ecosystem for you to practice meditation. So if you can, wherever you are in your seats, if you are on a couch, if you can come to a Siddhasana or a Chonkadi, by your cross leg, sit straight, and or if you are in your chairs, just sit there with your legs comfortably placed on the floor, on the foot on the floor, and with your back erect and in line with your neck. And it's always better to close your eyes, as Bala also advocated that if 60% of the sensations come from the eyes. And let's do what is called Alom Vilom, which is basically nothing but to breathe in from the left nostril. And if you breathe in for 5 seconds, please hold for another 5 seconds, and then breathe out from the right nostril for 5 seconds, and then breathe in from the right nostril, and then hold for 5 seconds, and then breathe out from the left nostril. This is 1. So let's do this 5 times and experience it. Please close your eyes. And if you cannot close your eyes because you have to watch me, that's also fine. So we breathe in from the left nostril, slow, gentle breathe in, inhalation. We hold the breath for as much time we took to inhale, and we exhale from the other nostril, slowly and gently, bringing our awareness to the breath. And then we slowly breathe in from the right nostril for as much as possible, equal amount of time that you took from the other nostril. Hold and breathe out. Try to do this 3 times. Try to resist the thoughts that try to make your mind wander, and bring it back to your breath. In fact, sit on the breath and follow the breath through the inhalation and the exhalation procedure, and do it 3 times. Breathe in slowly, gently. Hold the breath, and then breathe out from the other nose. This is Alom Vilom, also called Nadi Shodhan. As I mentioned in the first few slides, I recommended this for the anesthesiologists because you go through a lot of uncertain, unpleasant situations, have disrupted biorhythms, and lead a very, very stressful life, especially have lived such a stressful life with the last 2 years of COVID pandemic. Okay, and now let's do, you might have seen this word Ujjayi. Ujjayi is like a hissing sound, basically as the hissing sound that a snake produces. And I will show it to you. You can do it with eyes closed or eyes open, but basically you have to breathe from the throat with your all focus and concentration on the throat like this. No forceful breathing, no abrupt breathing, smooth, but breathing it from the throat and making that kind of a noise. This is Ujjayi Pranayama. So in one way you constrict your throat and breathe in like that. Breathe out with a normal exhalation as you do normally, and do this 5 times. Likewise, do it once more. Don't worry if you can't make the noise, just make a sincere effort, and later you can Google it and find it in the YouTube if you forget. Although I'll be happy to share these slides. Actually, I've already shared this with Dr. Babitha. Let's move from, Alom Vilom or Nadi Shodhan that we did, and we just experienced Ujjayi Pranayam. Let's now move to Bhastrika Pranayam. Actually, this is my favorite, and in my last 2 decades of professional career, when I was setting up my lab and, having all kinds of struggles and getting grants and putting it together, and even feeling a sense of failure of not being able to discover a drug. So a lot of stress was there, and I found this most healing, most elevating, and this is my favorite. This is called the Bhastrika Pranayam. It sort of activates your sympathetic response. So those who have whose shoulders, they have no heart problem, can do it as I do by throwing your hands up and breathing in as you throw those up. So gently put a fist next to your shoulder and then breathe in with the force and breathe out with the force like this. Those who have some shoulder problem, kind of averse, not happy with the jerky movements, can just do it as a Prime Minister also does. So it's like a more passionate inhalation and as forceful an exhalation. I'll just show it to you again. This is my favorite and love it. It energizes me. And if I start my day with this, I can work on and on for 14 hours without break. I love it, and I'm sure you will love it if you do it in this sequence. The first was Alom Vilom, second was Ujjayi, the throat one, and the third was Bhastrika. We'll try to now enter into a more pleasant phase, the Bhramri Pranayam, it's like a humming sound of a bee that you might have seen, and maybe you're already aware, then you can just do it with us. And the trick in this particular technique, in fact, for every technique, there is that small scope of improvement. Particularly for Bhramri, the scope is that you exhale for a longer time. So Guruji, Dr. Acharya Nagendra, the SVSA Vice Chancellor always says that you should try to increase the Bhramri time, which means, for example, I will show you by doing it for maybe 6-7 seconds. So he says that try to prolong it to 20 seconds, try to prolong it to 40 seconds. So it is said that Swami Ramdev can do this for 1 minute. So I'll try to show it to you. You basically have to close your eyes and put your this finger on the lips and like this, and close your ears with thumb, and then take a deep breath in and exhale with a humming sound like this. Then again breathe in, do this 5 times. And last time, do it once again. You just enjoy this moment as you do it and bring all the awareness to the present moment. So as you saw, you notice I could do it longer. Maybe I crossed the 10-second barrier. And finally, I'm going to end this with the best part, which is the belly breathing. Of course, I didn't have the scope to show you the asanas or the other kriyas, kapalbhati, etc. We focused only on the meditative aspects, the pranayama and the meditation. So the belly breathing is nothing but bringing all your awareness to yourself, to the current moment, and try to resist the mind wandering and do everything in a non-judgmental fashion. Non-judgmental from who is doing it, that is me. Non-judgmental from who is seeing you, which are others around you. Non-judgmental from whether you will get the benefits or not, and in any other imaginative fashion that you can describe or apply non-judgmental behavior. So we're going to end it with this, and this will take us into meditation. Belly breathing is just take your hand, right or left hand, on your tummy, on the navel, and close your eyes. As you close your eyes, and you can only listen to me, and just take all your awareness and your control to your breathing. You're breathing from your nostrils, both the nostrils, in a normal fashion. Take deep, gentle breath in and breathe out. You know this is normal breathing, but now this breathing is different because all your focus, all your attention is on your breath, the inhalation and exhalation. Since your hand is on the tummy, as you exhale, your tummy will expand. So be aware of that expansion. As you breathe in, it will expand. As you breathe out, it will shrink or contract. So do it again. Just keep your eyes closed. Continue focusing on inhalation and exhalation pattern, becoming aware by the touch of your hands on the tummy of the expansion and contraction of your tummy as you inhale and exhale. Keep doing it. All the noises around your room, whatever you're listening, don't resist them, listen to them, but again, bring it back to your inhalation and exhalation. Sit on the breath that travels into your lungs, and as it exhales out. In fact, imagine when it travels inside your lungs, and if that lung, it folds into alveoli, and if the particular folded structure is actually brought out, it may be half a Olympic tennis court length. About that much area will be covered by the amount of breath that is being folded into. As you exhale out warm air. You inhale and you exhale. Just keep your eyes closed and continue focusing your attention to your breath, the inhalation and the exhalation. Becoming aware of the amount of air that you're breathing in and how it is getting folded into your lungs, and then exchanging with the various alveoli, air with the vessels, capillaries, and then exhaling out the carbon dioxide, which is warm air from your nostrils. Imagine as much as possible of what you know of respiration and the respiratory physiology as you breathe in and as you breathe out. Don't resist the noises that come. Don't resist the fact that you are not able to focus. This is like your brain gym. Like you train your muscles with the weights. You're training your brain to focus on your breath. You're training yourself to meditate. You're training yourself to be in present. You are inhaling and exhaling, and you are also disrupting your multitasking at the moment, which is taking away the beauty of life, which is actually in the present. I won't speak anything but 30 seconds. Continue doing this on your own as sincerely as possible. The more you do it, the more you will be able to be in the current moment, because it's training the muscles of your mind and aligning it to the body. In fact, creating an excellent mind-body balance and a truly conscious state.
Dr. Akshay?
Now you can just come out of it, and that was the last thing we did. We are doing these kind of activities with the center as my last slide, and please try to join us in bringing all the folds of knowledge together into what is called the integrative medicine. And here is our Yoga Scholars PGIMER Facebook page. If you just Google Yoga Scholars PGIMER, you can see two anesthesiologists in this picture. So the anesthesiologists have been always on the forefront in implementing yoga, at least in PGI. Thank you very much for your attention. I'll be happy to take questions.
Thank you, Dr. Akshay. And extremely sorry to interrupt the very quiet state which we had all reached, but we were crossing the time. So I'm very, very sorry to interrupt you in between. I must say that it has been an extremely elaborative talk, ranging, taking a journey from the history of the yoga to the evidence of yoga, implication of it in the clinical practice, to the evidence, to the finally practical aspect of the yoga. Thank you very much. Dr. Akshay, I'll be taking first question, which is from Dr. Jairam Panikar. Is there any quantum relation to consciousness? Hameroff and Penrose postulated about the quantum states of microtubules.
Thank you for that question, and actually do not have a very firm answer, as also endorsed by Dr. Bala. Yes, so there are theories that the consciousness actually lies in the cellular consciousness lies in the cytoskeleton. But those are just theories. There are no tools to measure the states of consciousness. EEGs give us some way out, but in terms of consciousness, as of now, I think it is only to be experienced and felt. Probably the only frontier left unmeasured. We have to develop tools for that.
Thank you very much. And there is a compliment from Dr. Atul Sharma. Excellent thought-provoking talk. Thank you very much. And I would just like to beforehand to the ICA. I would like to congratulate Dr. Akshay to bring collaboration in collaborating the alternative medicine to the clinical practice. And we both are together working hugely in the field of yoga practice in the chronic low back pain, and we have developed our own yoga protocol, published it. It's on the way of publishing. So over to ICA team now. Hello. Am I audible?
Yes, you are.
Baljit sir. Good evening, Bala sir. I have a lot to ask Akshay, but already crossed 3 minutes.
Yeah. Dr. Anand would like to say a few words before we wind it up.
Thank you, Baljit. I'm sorry I was not able to hear the first part. I came a bit late. Anyway, I heard the second part. Went well, I must say. It was a really very consolidated approach to the topic. And I thank Dr. Bala as well as Akshay in giving us more complete knowledge on the matters. And I request you to go ahead and close the webinar.
Thank you.
Well, thank you so much, friends. This was an entirely different dimension that we have been engaged in for more than a year, academic activities. Entirely different dimension that, in the sense that we have been discussing anesthesia, various aspects of it, and this is absolutely different thing that we have discussed today. I'm a total novice, let me say. I'm absolutely at sea with regard to these things. Apart from the fact that everybody knows that yoga practice reduces stress. The way it's been explained by Dr. Akshay Anand, I think it was very, very fascinating and a very thought-provoking one. Before that, Dr. Bala Subrahmaniam took us to another new field of unconsciousness tendency. I listened to just about half the talk because I was late in my hospital. But whatever I learned, I tried to grab it. It took me quite some time to sort of get the level of comprehension just because of my own ignorance with regard to this thing. But well, yes, it was new knowledge to me, and I've learned a great deal from this. With regard to the way Dr. Akshay Anand had explained, I think it will take me 2 or 3 visits to his presentation again and again to learn more about it and put it into practice. I think this would be some, anesthetists are known to suffer from a very high degree of stress during their, professional working hours because of the nature of job is such. If airway is not patent or airway is at risk, of course, the kind of stress you can only experience it. You can't describe the kind of stress that you have. And that sort of stress which we face in our daily life, if we can reduce that sort of stress and the harm that it can cause in the long term, I think yoga would that way would be a standout performer with regard to with regard to the good health. Well, I have no words to thank both the speakers for the excellent talks, Dr. Bala Subrahmaniam, as well as Dr. Akshay Anand. Thank you so much for very, very thought-provoking and adding a new dimension to the practice of anesthesiology and how we can use these for our greater good, for our good health. Thank you so much. And with this, I think we can close the webinar for today.
Babitha.
On behalf of Indian College of Anesthesiologists.
Thank you, sir.
And thank you, Babitha, for excellent moderation.
Thank you,
Sorry,
ma'am.
I missed out Dr. Babitha. She very nicely moderated. Thank you, Dr. Babitha. My apologies for.
Not at all, ma'am. Not at all, sir.
She's
Thank
a
you
part
very
of us.
The session was very well moderated.
Thank you very much. Thank you very much.
Thank you.
Bye-bye. Bye.
Bye-bye. Thank you very much. Thanks, Bala. Thanks, Akshay. Good night. Good night.
Bye, ma'am.
Bye, Sanish. Bye-bye.
Bye-bye.
Webinar will finish at 8:30.